Asante. Kama bado tumesimama, wacha tuongozwe kwa maombi na Madam Mary Mwiti ambaye ni CEO Council of Governors. Madam Mary Mwiti, popote ulipo, tafadhali kwa heshima.
Let us believe and pray. Heavenly Father, in the mighty name of Jesus, we come before this morning. We want to give you glory, we want to give you thanks for who you are. We want to thank you most sincerely for the gift of life this morning and for the gift of gathering this morning, O Jehovah, as we start off this meeting that is coming to discuss critical issues of health in this country. We pray that you're going to inspire us with your knowledge and wisdom, that you're going to guide us and guide us to the right footing, and the resolutions that you're going to make out of this meeting shall be for the greater glory of the people that you've called us to serve. May you start with us. May you guide the Deputy President. May you guide the Chair of the Council of Governors, the CS, and all the governors and other people that are assembled here, so that, my God, my Father, as we front every discussion, we do it knowing that with humility we are going to serve this country that you've bestowed the honor for us to serve. We bless you as we start off, and when we end, we shall be careful to give you glory and honor. And it is in Jesus' mighty name I pray and trust. Amen.
Asante, tafadhali tuketi sote. Mheshimiwa Naibu wa Rais Profesa Kithure Kindiki, Waziri katika Wizara ya Afya Dr. Dibora Mulongo, katika katibu wakuu katika wizara husika mliofika, anayemwakilisha Waziri wa Fedha nchini Bwana Francis Anyona, magavana mliofika chini ya uongozi bora wa mwenyekiti wa Baraza la Magavana nchini Mheshimiwa Ahmed Abdullahi, washikadau wote, mabibi na mabwana, hamjambo. Kwa ruhusa yako Mheshimiwa Naibu wa Rais, nikubalie nikupe ushukani utufungulie kipindi hiki cha majadiliano ya masuala ya afya katika taifa letu la Kenya, ili uweze kutuelekeza na pia uweze kuwakaribisha wageni wako ambao tunashukuru sana Maulana kwa sababu ya kufika kwao, kwa sababu ya kujadili masuala haya ya afya, ya kuhakikisha taifa letu liko katika mahali salama kiafya. Karibu sana sana.
Colleagues from the national government and county governments, all protocols observed, good morning and welcome. We began from the national government side. We have had our meeting since 7 a.m. I just want to thank the county teams, the governors led by the Excellency Governors, for making time to attend this meeting, and all the other colleagues present representing various organizations. Health is one of the most important interventions that this administration is focused in delivering. The manifesto of Kenya Kwanza places health as one of the pillars for the delivery of services to the people of Kenya. Many countries around the world have struggled with providing universal health care for its people. It is not an easy job. Providing universal health coverage is a complex, expensive, and I dare say politically risky enterprise because of the requirements that go with its delivery. However, this administration is committed in partnership with the county governments to deliver universal health coverage for the people of Kenya. I want therefore to thank you for finding time to attend this very important meeting and appreciate your inputs, even as we look at where we are in the implementation of this program, which started 5 months ago. I want to acknowledge the leadership His Excellency the President has given to this process. I also want to acknowledge the role being played by the Ministry of Health, led by the CS, Dr. Mulongo Barasa, who is here, and the PSs, Mary Mudhoni and Harry Kimtai, and the other senior officials from Afya House. I also want to appreciate the role played by the President's Economic Advisor, Waziri Moses Kuria, who is here with us. He's shown a lot of interest and keen support for this program. I want to appreciate the role played by Excellency governors in supporting this program. I really want to say that without the support of all the governors of our country, this program would not have enjoyed the kind of takeoff that we have witnessed in the last 5 months. So, Chair, on behalf of the COG, thank you very much for support and the cooperation that we continue to enjoy as national government in this endeavor. Allow me to say a few things, because today really is not a day for speeches. Today is a day to take stock of where we are, what the issues are, and then devise ways of making sure that we go into the next gear, which is to upscale the rollout and firm up on the initial turbulence that you expect of a program of this nature. I'd like to highlight just a few things. First is that in terms of registration, we seem to be making good progress. 19.5 million Kenyans are already enrolled. However, the situation as it is to firm up on the contributions. And as many of us are aware that at the moment we need to do some work to make sure that as many people as possible who have registered are making contributions. And for the avoidance of doubts, out of the 19.5 million Kenyans, all of them are enjoying primary health care, which the government is providing free of charge for the primary health care. Now, in terms of other forms of care, the secondary forms of care, treatment and referrals, we have quite a number of Kenyans who have registered but are not making contributions, and we must find a way of ensuring as many people as possible are paying their contributions so that they can enjoy the full health package, health benefit package that is available beyond the primary health care, which is available for everyone who has registered. Number two, we are reviewing the means testing tool, and I think the ministry will be giving us progress of where we are. In the next few days, we will have a new means testing tool to make sure that the tool is accurate, objective, and helps us leverage on all the fundamentals to make sure that we provide quality health care to the people of Kenya. That means testing tool will be informed by data, and there is ongoing work to integrate critical data to be used in the revised means testing tool, which has been revised following the feedback from members of the public and stakeholders that we have received over the last 5 months. And therefore, going forward, we expect, once that process is complete, we expect a more energetic rollout again, because the target of the UHC program is to make sure that every citizen of Kenya has a medical insurance cover. It is possible, and we are focused in making sure that that possibility is realized in the shortest time possible. In terms of other interventions that have been made, especially with regard to the financing of the program, I think there will be, at the end of the meeting, we'll be announcing the measures that the national government has taken through the supplementary budget, which is going to be presented before the National Assembly tomorrow, to make sure that some of the feedback we have received about financing this program around emergency critical care and chronic ailments, that again has been factored in to make sure that we are able to ensure full benefits to that category of patients. Again, this has come from the feedback that we have received around those areas, around ICU treatment, HDU treatment, and critical and chronic diseases. Other than that, as you're aware, the health sector, part of the health sector is financed by development partners. Some of the development partners have made certain policy changes recently. I just want to assure the nation that we remain focused to make sure that any policy decisions by our development partners does not affect the delivery of healthcare services to the people of Kenya. So part of that discussion will be held here this morning, but I want to give that assurance that our objective as government is to make sure that no decision that is made by our development partners affects the quality of healthcare we provide to the people of Kenya. So we're making all necessary contingency decisions and arrangements to ensure there will be no disruption of services to the people of Kenya. We are also expected this morning to look at the human resources aspects of this program, and I think there are a number of issues that are outstanding, and I hope this meeting, now that the two levels of government are represented here, are going to iron out some of the outstanding issues about HR in terms of the responsibility for UHC staff and other staff in the health sector, and also the issues around interns and the issues around CBA for health workers, and so that we can make sure that the human resource component is also not left behind, because it's a key determinant of delivery of this process. At the same time, this meeting also will be expected to deal with the issue of the capability of our health institutions and health facilities to provide the required services, and therefore the National Equipment Support Program, and how we again expedite the outstanding issues around ensuring that our health facilities have the necessary capabilities to deliver services is part of the outcome for this meeting. Lastly, I think the issue of digital health, and the whole issue about digitization of our health, of this program, there is ongoing work, and we'll be receiving progress reports in either the presentation from the Minister of Health, or also alternatively from the panel discussions that we are going to have this morning. So broadly, that's why we are here. We have started well. There are a number of issues that we need to address to perfect the program, including capability of facilities, financing, human resources, and making sure that there's a means testing tool that is accurate and provides optimal results for this program. Other than that, I just want to end my remarks by reiterating that for the Kenya Kwanza administration, this universal health coverage, Taifa Care, is essentially the most consequential intervention that this government is making. It is personal to every Kenyan and to every household, and given its importance, we are not leaving anything to chance, and I just want to plead with all stakeholders, development partners, government agencies, national government, county governments. We have a moment to make history. Even some of the most advanced economies have struggled with universal health care with mixed successes, not so much successes. We are determined, not because of anything else, but because we believe this transformation of our country, the economic transformation of a country, relies on a healthy population. And therefore, health and perhaps education are the two social sector enablers that will help us transform Kenya using the other pillars of economic transformation, that is job creation, infrastructure, value chains, and also just making sure that we retain long-term macroeconomic stability for our country. With those many remarks, I want to end there and invite Chair maybe to make a few remarks, and then we proceed. Thank you very much, and karibuni, asante. We will finish with a communique to the country, because we need to speak to the country and say what we must say, and just set the record straight and affirm Taifa Care, because we must affirm Taifa Care. Makofi kwa Chair COG.
Your Excellency, the Deputy President of the Republic of Kenya, fellow Excellency Governors, CS Deborah Barasa, Cabinet Secretary for Health, Principal Secretaries, CCs for Health and other officials present, stakeholders in the healthcare sector, distinguished ladies and gentlemen, good morning. I'm honored to join you here today, Your Excellency. Today's meeting provides a platform for us to jointly discuss, learn, innovate, and share experiences on health by fast-tracking our journey towards universal health coverage. Additionally, meetings like this will foster intergovernmental coordination and cooperation, thereby making the national and county governments to be more effective and efficient in their roles. In this regard, allow me to take this early opportunity on behalf of the Council of Governors and on my own behalf to thank you all for attending this forum. Your Excellency, ladies and gentlemen, for almost a decade now, county governments have contributed tremendously to the healthcare of our people. Devolution has significantly empowered counties to tailor healthcare services to local needs, making healthcare more accessible and responsive to our communities. Whether you look at the northern frontier counties, which had unique health and development challenges that were related to long-term suboptimal resource investment, or you have a glimpse at cities like Nairobi, Mombasa, and Kisumu that have their health needs stand out because of the large population concentrations in small areas, you will not fail to acknowledge that the progress that devolution has brought to the Kenyan health care sector. Each one of you has played a unique role in realizing these gains. Despite these gains, there are pressing challenges that require our collective effort and collaboration to overcome. Allow me, Your Excellency, to highlight just a few. And one, the transition of services in social health insurance. First and foremost, there are a limited number, precisely 5,380 claims processing devices in counties. In addition, there are frequent system downtimes and inadequate e-claims machines, hampering efficient claim submission and reimbursements. Expanding the device distribution and improving system reliability are essential for streamlining financial flows and enhancing service delivery. Secondly, there has been delays in implementing capitation for the level 2 and 3 facilities, creating financial instability. Timely capitation payments will provide predictable financing for these facilities and ensure continuity of service. It's important at this point to note that counties are owed Kenya shillings 7.5 billion in unpaid NHIF reimbursements, which is severely compromising their service delivery. Immediate settlement of these debts is critical to restoring financial stability. Thirdly, the primary health care fund and the emergency, chronic and critical illness funds need to be fully operationalized. Your Excellency, the National Equipment Service Program, NESP implementation, is another matter I would like to discuss. The implementation of the NESP as a fee-for-service model to replace the Managed Equipment Service, which was commonly referred to as MES, prevents an opportunity to enhance access to specialized services such as renal care, radiology, and intensive care. However, clear guidelines and sustainable financing mechanisms are required to ensure counties can manage and sustain these services post the contractual period. The impact of the US government's work order on health services is another challenge. The recent stoppage of work order by the United States government has exposed our over-reliance on external donor funding for key health programs. This order has significantly affected critical services, including HIV, malaria, TB, family planning, and immunization programs. For example, about 11,000 healthcare workers who are financed by the US government across the country have been affected, threatening service continuity in both public and private facilities. There has also been disruption of the health management information system, particularly the Kenya EMR system, which is crucial for managing HIV data. The loss of funding for HIV commodities can be estimated to be around 13.5 billion shillings annually. To address this, we must take decisive action to integrate donor-supported systems into our health system and ensure sustainability. We must also prioritize domestic resource mobilization to reduce our dependency on external donors. The healthcare workers' industrial unrest is a perennial challenge. It's a pressing issue that's unresolved. that is the labor concerns within the healthcare sector. The delayed implementation of the return to work formula, the incomplete absorption of UHC staff into permanent and pensionable status have led to significant unrest among healthcare workers. This poses a serious threat to service delivery and continuity across the country. We must urgently address these labor issues to ensure a stable and motivated workforce. Last but not least, community health promoters funds flow. Your Excellency, this still remains unresolved even after several resolutions of the summit and the IBEC. The CHP is the lowest level of service provision. Hence, to ensure consistency and accountability of resources, a conditional grant was to be granted to counties for the counterpart funding from the national government, the matching fund from the national government, to ensure synchronized payment point. Your Excellency, ladies and gentlemen, as a Council of Governors, we knew that the implementation of universal health coverage will not be without challenges. But we believe that beyond the teething problems, the average Kenyan will be better for it with regard to access to healthcare. The challenges facing our health sector are indeed complex, but they are not insurmountable. Through structured collaboration between the Ministry of Health and county governments, we can build a resilient healthcare system that serves all Kenyans efficiently. I urge us all to approach today's discussions with a commitment to finding practical and sustainable solutions. Let us work together to make affordable and quality healthcare a reality for all our people. I thank you, and may God bless us all.
Makofi mazuri jameni. Asante sana Mheshimiwa Abdullahi. Kwa ruhusa yako Mheshimiwa Naibu wa Rais, nikubalie ni mwalike waziri katika Wizara ya Afya aweze kutuelekeza katika kipindi kifupi kifuatacho cha maonyesho ya kina ya wizara hii na vile vipengele ambavyo vinafuatia. Karibu sana Dr. Dibora Barasa. Tafadhali tumpe makofi kidogo. Karibu madam.
Thank you very much, Your Excellency, the Deputy President, COG, the governors, Your Excellency, COGs, all protocols observed. Good morning. So we'll give an update on implementation of Taifa Care. And we will begin with the benefits package. As you know, this was our benefit package for the primary health care. What we had informed Kenyans is outpatient, inpatient, maternity, and optical services for minimal tariffs. But what was excluded in the first year was end-of-life services and screening and management of precancerous lesions. Regarding the social health insurance funds, then we had the benefits that are there, which is inpatient, maternity, renal, hemato-oncology, mental, surgical, imaging, among others. Incorporated and bold is overseas treatment, which again has been highlighted, but it was actually incorporated in year one. But those that were included in the shift included outpatient and oral health dental services. Regarding emergency, chronic, and critical illness, what we had said is emergency evacuation, stabilization, and resuscitation. And what was excluded in year one was critical care, chronic illness, assistive devices, and palliative care. And so even as been highlighted by His Excellency Honorable Abdullahi, critical care has been a challenge, and we have good news with regards to that, equally regarding the primary health care and the overseas treatment. So regarding the establishment, we have established the benefits package and tariffs advisory panel, and they will be reviewing the benefits package every 2 years. That is to identify the concerns and critical components that need to be addressed urgently, and for them to be implemented as we had seen earlier, such as the critical illness. And the UON, through the Center of Epidemiological Modeling and Analysis, is going to host the panel and joint secretariat. So the vetting of the nominee CVs is ongoing, and a review of the MOU is underway. It will be signed by 24th February and gazetted by 28th February. So we want to assure you, governors, we are not sleeping in terms of benefit package. We have advisory team on board, and if there are any concerns and grievances, then they'll be exhaustively addressed by this. So these are wonderful news for us. We have revision of the benefit and tariffs package. There's additional funding through the supplementary budget to facilitate, number one, an increase in funding for ICU. Previously, we were at 4,480. We are happy to report that now ICU will benefit from 28,000 Kenya shillings per day. Equally, that's good news. So again, for oncology services, we are happy. Previously, we were at 150,000, and following concerns from the public, we have been able to increase. Sorry, we're at 400, but we have increased to 550,000, an additional 150 for the oncology cases. So again, that is a good point for us. And equally, in the later slides, you'll see the issue of procurement, bulk procurement, to ensure that the prices of some of these medications are worked on. And after review, the revised benefits will go through the legal process for gazettement. Again, another concern that has come up from Kenyans is the overseas treatment, and the SHE Act provides for overseas purchasing of healthcare services not available locally. However, this requires accreditation, empanelment, and contracting of the providers and facilities overseas. And so we continue undertaking overseas treatment. Work is ongoing. We need the Ministry of Health, KMPDC, to review the patients who are going outside, and after giving they can go outside, then they can be seen. But let us remember that currently we are having 500,000 shillings for this, all inclusive. So maybe I can highlight, at times some of these things may not be addressed. It's important that they go through review by KMPDC, they go through review by Ministry of Health before they are released, because we've had challenges of patients going to facilities that have not undergone the right accreditation, or asking for money to be sent into their bank accounts, etc. So this again is a need-by-need basis, and needs a review by our team. Again, means testing. Previously, as you know, our previous means testing, people would cheat the system, and this has had great impacts in terms of our average. You'll see later on, our average currently is at 560, I believe, and yet we need 880 for this as an average means testing for the system to be sustainable. And so we went back to look at the means testing, and we have a new algorithm which is under development. And it will rely more on data triangulation from other existing databases in government agencies for improvement of the accuracy of means testing. So the database will include KNBS, KRA, Immigration Department, Hustlers Funds, KPLC, among others. So the data has been requested. We are collecting all the data and reviewing it, and we believe that we should be able to roll out the new means testing very soon and plug it into the insurance premium financing, because ultimately for the system, for Taifa Care to be sustainable, we need to have the resources at hand. So we want you to encourage people, even as they register, they need to contribute. That way, when we have resources, sustainability is again successful. So our key asks, first of all, is the funds for payment of old NHIF debts. As you know, there are a bit of lamentations from healthcare providers, and so we are working to, finish up on that debt. Equally, the civil servant scheme that is included to facilitate access of healthcare services for our civil servants. Again, additional funding for improvement of benefit packages because of the concerns that have been raised by the Kenyan people, and identification and financing of indigent population by counties. IPF implementation, again, to support informal sector is really critical. That way we can have contributions up and running and have a successful implementation. Again, we need your support, dear governors, in the rapid registration initiative for SHA registration as well as a premium payment in the counties. That way we'll have enough resources to make it sustainable. Regarding human resource for health, for the CHPs, we have more than 107,000 CHPs in Kenya, and the national government has provided 100,000 CHP kits. And government has allocated resources for the payment of 100,000 CHPs in the country, 2,500 from national government, 2,500 from county government, totaling to 5,000 per CHP per month. And the payments of CHPs across all counties have been effected up to the month of December 2024. 8,571 staff have been transitioned under the UHC program, and process on the implementation of commitments made to doctors, nurses, and clinical officers is ongoing. Equally, public officers medical scheme for funds for public officers is ongoing. So these are the commitments for return to work formula for the doctors, and you can see the issues raised, including basic arrears, internship, harmonization of union members' employment by national government, postgraduate arrears, among others. And we are happy to report that 11 of these issues have been addressed. The one remaining is the internship component and conclusion of the CBA. As well as employment of additional doctors to support the implementation of UHC. So I think we need to highlight that during our meeting in November, December, we talked about 206, but for the new cohort, we are talking about 70,000. And so negotiations will start to ensure that, again, this is implemented. So the ERLC in Eldoret rendered judgment on consolidated petitions on 17th October, upholding the legality of SRC circular. However, the court observed that SRC rates were at variance with the 2017 CBA, and it directed that we negotiate with the KMPDU within 90 days. And to forestall the strike, as I said, we met in December 2024, and interns again were posted. The CBA rates were effected, and now there's a current cohort that will be joining of 4,332 in all cadres, and there's need to resolve the salary or stipend rates of the interns once and for all. So as I said, we'll be having meetings, and as you can see, these are the 4,332 graduates broken down in the various cadres, medical interns, dental pharmacists, etc. And below you can see the budget requirements for up to 2025, for June 2025 from financial year 2024-25. So you see that using the SRC rate, we will be able to save a lot of resources and support to the doctors, and we look to, and other healthcare workers. So we look to start our engagement with regards to that. Regarding the pending CBA and negotiations of new CBA, cognizant to the respective independent corporate existence of the various entities under national government, KMPDU shall within 90 days from the date of this agreement conclude on the CBAs for each, and the employers will on a priority basis seek the advice of SRC. So concluded was the CBA for Nursing Union for clinical officers is ongoing pending with the Treasury, and the KMPD is to audit the status of implementation of 2017 CBA and present the report for deliberations. For the doctors, additional doctors to support UHC implementation, the government shall establish mandatory staffing norms for various levels, and in furtherance of this national endeavor, the government shall employ 2,000, and thereafter establish a policy for annual recruitment and placement of doctors, pharmacists, and dentists. So a technical working group and steering committee developed a HRH policy, and the Ministry of Health Staffing Norms and Standards reviewed the policy that was developed, and the employment of doctors will be done over a period of 2 years, beginning financial year 2025 to 2026. Funding will be provided for either in the 2025-2026 budget, a budgetary provision of 6 billion is required, and the hiring will depend on the needs and based on the results. The hiring will be at various levels, from ministry, county, and at the national hospitals, the semi-autonomous government agencies. Regarding health commodities, KEMSA's mandate is procurement, warehousing, and distribution of HPTs, and it partners with counties and strategic partners. They have, they're using LMIS to collect, analyze, and provide regular HPT reports, and they support counties in health supply chain strengthening. The key role in UHC, accessible and affordable quality health products, and extending economies of scale to the counties. KEMSA, however, faces challenges in endeavor to ensure sustainable stock availabilities. The challenges, you can see stock availability stands at 53%, and order fill rate after back orders on average is 65%. Constraints affecting stock availability, COVID-19, health program, HPTs strain the cash flow, and the long-standing debt of 6.1 billion. Counties contributing 3.5, MOH 1.4, and development partners 807 million. There is also delayed payment to suppliers, with 1.5 billion being over 90 days. And you can see the total pending at 2.4 HPT and procurement for 2024-2025, and the projected cash flow needs being 8.5 billion. So key asks to counties: to settle the outstanding bills by counties to restore financial stability. That way we can have improvement in capacity at your facilities, and also KEMSA. COG to concur on debt remittance of direct remittance of debt from TNT to KEMSA in concurrence with COB, and the COGs again to concur on net off by SHA to KEMSA for SHIF and PHC HPT debt. We'd love to hear more about implementation of that. Then concurrence that KEMSA remains the first choice for all public health facilities. That will be able to capacitate it and ensure that supplies are always there to reach the last mile. Regarding a comprehensive integrated health system, the objective was a national comprehensive health information management system to enhance efficiency, effectiveness, transparency, and accountability. And MOH contracted the consortium led by Safaricom. So for the digital superhighway, you can see those are the components: the health information exchange or the registries, and the health management information system. And those are the systems, the e-claims, SHA, ERP, registration, and National Logistics LMIS. So what have we been able to do so far? For registration, we are happy to report that we have self-registration, assisted registration, employer portal. We had our means testing, but we are reviewing to have the new means testing that will incorporate the various data agencies that we had talked about. For the claims insurance management system, we have the provider portal ready, and the claim payer engine and post office system. They are reviewing and working on the SHA ERP. We've been able to distribute 5,665 devices, and 3,000 are in the warehouse, and 62,000 will be delivered by March. Regarding health information exchange, we are happy to report that we have the clients registry, the health worker registry, facility management system, the health terminology, and national shared health records. Now they are able to be rolled out efficiently. HMIS development was complete, baseline survey ongoing, and HMIS rollout to follow in suit. Training, 11,600 have been trained, and 71 physical trainings have taken place. Supportive supervision and mentorship is ongoing. Our key asks, I think we had a best practice from Mombasa, and we want to encourage counties to implement this with more than 87.5 of their facilities being digitized. And I believe His Excellency the Governor will give a best practice and how he's been able to secure resources and ensure sustainability. So we are encouraging the signing of intergovernmental participating agreements, conducting baseline assessment per county on what is available, and then uploading all the healthcare workers to the Health Pro. So another concern that has been raised is US government funding, and what is the ministry doing about that? As we know, the global fight against HIV, TB, malaria is mainly supported by PEPFAR, PMI, Global Fund, and UNAIDS, and all deriving quite an amount from USG. Kenya has been overly dependent on the donor-driven vertical health programs, and yet there was a stop work order which has disrupted USG funding worth 30.9 billion. HPT being 24.9, HRH 5.8, HMIS and health system strengthening also being affected. Additional multilateral funding for vaccines, nutrition, family planning of about 17.2 billion are also at risk. And then the public health security may result to service disruption because of lack of commodity security, HRH, and data systems being affected. So what is the status? Currently, we have 1.4 Kenyans living with HIV on ART, and we are at risk of having 58,495 new infections by 2030 if donor funding is reduced. For TB, we are likely to have 23,500 TB annual mortalities, among them being 20,000 people living with HIV. And for malaria, we're likely to have 12,000 deaths per year, with projected increase because of climate change. And for family planning, 6.2 million who rely on family planning annually are likely to be affected, and yet the gap of 40% has not been reached. Regarding vaccine, coverage currently is at 77%, and the program is currently under transition from donor to government funding. So that coverage of 77% is likely to be hampered. So as we said, for commodities, 24.9 is by US government, 79.8 to Kenya, and 79.8 health commodity need. That is 24.9 out of the 79.8 commodity need. And we are engaging diplomatic interventions. On Wednesday, we'll be meeting the US acting ambassador, and we are also developing an impact assessment of which we will be sharing with the various development matters and diplomatic for interventions. We also need to allocate 24.9 billion for commodities previously funded by USG, and disburse 2 billion allocated, and allocate additional 2.5 for vaccines to avert funding freeze by Gavi. For HRH, we have 41,547 PEPFAR-funded staff affected. And after reviewing, the technical team reviewing this, we saw that 11,559 frontline health workers would be core in terms of transition and implementation, and their cost is 5.84 billion. And there is need for us to approve comprehensive HRH restructuring and highlighting with public health systems. So 41,000, but 11,000 core, 41,000 having been able to support us in implementing the 98, 94 targets. And again, we look to to capacitate the team that will continue with the interventions. For data, USAID funds 139 million for critical health-based databases, including Kenya EMR, among others. And we are happy that we have a digital platform, so really it's on time, and we are really ensuring that we are transitioning to the digital and integrating those critical data so that we don't lose important patient data through the cracks. Other critical programs are the blood transfusion program, where 2.8 billion World Bank support is ending in March 2025, and we are securing other funding. This is because one of the high causes of maternal mortality is hemorrhage, postpartum hemorrhage, and so we need to address blood transfusion concerns. Immunization and vaccines, 11.6 billion is required. Gavi and USG support again is at risk, and the recommendation will need disbursement of 2 billion immediately and allocate 2.5 billion for Gavi compliance. Family planning require 2.7 B. USG was 598, GOK 508 with the 1.7 form funding gap. And the recommendation is to allocate 598 for continuity and consider 1.74B in 2025-2026. Equally for nutrition, 4.96 billion required, 2.88 from USG is at risk, and will replace USG funding with domestic allocation. So in summary, you can see from the various pillars or departments, the total is actually coming to 30.922 billion that we require for seamless transition. So our asks, retaining for the counties to retain all healthcare workers for integration of the vertical program into the mainstay human HSS health system structure, and then restructure HRH to the core human resource and integrate the vertical component to Taifa Care, and counties to set aside funds to aid transition from the donor-funded programs. We also need to capacitate our human resource for health even as they transition, so that we don't reverse the gains that we have accrued over the 40 years. So thank you so much. Over to you.
Makofi mazuri jameni kwa waziri wa afya nchini. Asante sana Dr. Dibora.